In this module, we'll look at alveolar bone. The alveolar bone or alveolar process is defined as the part of the maxilla and the mandible that form and support the sockets of the teeth. The alveolar process extends from the basal bone of the jaws and develops in conjunction with the development and eruption of the teeth. The alveolar process consists of bone that is formed both by cells from the dental follicle to produce the alveolar bone proper, and cells which are independent of this follicle to produce the actual alveolar bone. Together with the root cementum and the periodontal ligament, the alveolar bone proper constitutes the attachment apparatus of the teeth. By way of review, the portion of the maxillary mandible that contains the teeth is called the alveolar process. It is solely a tooth-supporting structure which can be lost due to disease, lack of function, or excessive forces. Here you see the alveolar process on a dry skull, and here is the outline of the alveolar process on a radiograph. This is a cross-section through the alveolar process of the maxilla at the midroot level of the teeth. Note that the bone which covers the root surface is considerably thicker at the palatal than at the buccal aspects of the jaw. Anatomically, the walls of the sockets, the alveolar bone proper depicted by the black arrows, as well as the outer walls of the alveolar process, are made up of cortical bone, sometimes also referred to as compact bone. The area enclosed by the cortical bone walls is occupied by cancellous bone, also called spongy bone. Thus, the cancellous bone occupies most of the interdental septa. The cancellous bone contains bone trabeculi. The trabeculi's architecture and size are partly genetically determined and partly the result of the forces to which the teeth are exposed during function. Note how the bone on the buccal and palatal aspects of the alveolar process varies in thickness from one region to the other. This histologic specimen illustrates a section through the interproximal septum between two premolars. Dense alveolar bone proper, designated by ABP, is facing the periodontal ligament of the two teeth, while cancellous bone occupies the area between the alveolar bone proper. The cancellous bone is comprised of mineralized bone, designated by MB, and bone marrow, designated by the letters B and M. Now let's review a few more terms. The alveolar crest is defined as the highest point of the alveolar ridge that joins the facial and lingual or palatal cortical plates. On the left, the arrow is pointing to the alveolar crest on a dry skull, and on the radiograph on the right, the arrow is pointing to the crest as seen on a radiograph. The outer walls of the alveolar process are made up of cortical or compact bone. The area enclosed by the cortical bone walls is occupied by cancellous bone, also known as spongy bone. So on the left again, on the dry skull, we can see the outer process of the mandible, which is compact bone, also known as cortical bone. In the cutaway on the right, we see the inner aspect known as the cancellous bone or spongy bone. Now, the laminadura is a unique feature in the fact that it is solely a radiographic image of alveolar bone proper in the alveolar crest that is sometimes present. Its appearance may be dependent on the X-ray angulation and was shown many, many years ago to actually be a radiographic artifact. You can't count on the presence or the absence of a laminadura to indicate a status of health. The presence or absence of it is not an indicator of disease, nor is it related to parameters of inflammation. The Cribriform Plate is an alveolar bone structure, as you see here, which has many perforations. This is to allow for the passage of blood vessels and nerves to the tooth socket. Here in cross-section is a view of the entire structure. You can see the lattice-like structure of the trabecular bone, as well as the dense outer cortical bone or compact bone. On the right, The radiograph demonstrates the fine radiopaque lines representing the trabeculi that you would see on the inner aspect on the left. Now, bone matrix is a complex structure which consists of intracellular organic matrix with collagenous fibrils that are primarily type 1 collagen. This sits in an amorphous extracellular matrix containing inorganic salts. The extracellular matrix consists of a variety of glycoproteins and proteoglycans. The inorganic salts are calcium, phosphorus, calcium carbonate, and sodium crystals bound to collagen fibrils. They typically constitute up to 65% of the bone's weight. Three important extracellular non-collagenous matrix proteins are osteonectin, osteopontin, and osteocalcin. Osteonectin is normally released from multiple cells during inflammation. Osteopontin is produced by osteoblasts, osteoclasts, and macrophages with increased levels found in active sites of bone metabolism. Osteocalcin is an extracellular matrix protein that is associated with bone formation. Several different cells are also found within bone. Osteocytes are present within lacunae and are surrounded by a 1 to 2 micron mineralized matrix zone. Osteoblasts are bone-forming cells derived from precursor cells originating in the connective stroma of the periosteum. Haversian systems, endosteum, and marrow are all part of this. They synthesize type 1 collagen and ground substance and initiate the process of mineralization by means of membrane-bound vesicles. Osteoblasts that have become trapped in the matrix become osteocytes. Osteoclasts are multinucleated cells that are bone-resorbing cells that arise from the fusion of monocytes. They are typically found in a structure called house-shaped lacunae on bone surfaces and envelop the end of bone spicules. Compact bone consists of Haversian bone containing Haversian canals, which serve as tunnels for small blood vessels. These canals run parallel to each other in the long axis of the bone. The blood supply comes either from the periosteum or the marrow cavity through Volkmann's canals, which run perpendicular to the long axis of the bones. And on the right, you can see the osteocytes that are trapped within the bony structure. Cancellous bone consists of a trabeculi or spicule networks which follow the lines of stress. The spaces between the trabeculi vary in size and shape. This tissue is either of hematopoietic, myeloid, or fat origin. The trabeculi consist of osteocytes embedded in lacunae and irregularly arranged bony lamellae. There is not a distinct Haversian system since blood vessels are never far away, typically less than 0.2 millimeters. The surface of the trabeculi is covered with a thin layer of osteoprogenitor cells and occasional osteoclasts, which is known as endosteum. Put all together, you can appreciate the intricate detail of the compact bone with the distinct lamellae and blood supply that is running through the osteons. In addition, the lattice-like trabeculi of the cancellous or spongy bone is seen on the right. Here, the close proximity of the blood supply is seen. Occasionally, there can be outcroppings of bone that can be found throughout the mouth. One such type is seen on the left and is termed a buccal exostoses. These are broad-based, non-malignant surface growth that occurs on the outer or facial surface of the maxilla and or mandible and is usually found in the premolar or molar regions. The etiology is not well known, but it has been suggested that the overgrowth can be caused due to an increase of masticatory forces to the teeth. They tend to appear in early adolescence and may very slowly increase in size with time. On the right, we have a palatal torus. Now, tori can also be present on the mandible, but typically you will find palatal tori in 20% of all patients, with Caucasian females exhibiting the highest prevalence at 27%, and females almost showing a 2-to-1 prevalence ratio over males for having palatal tori. In addition, Caucasians are found to have these more frequently than African Americans. One other aspect of the alveolar bone that you may run across is something called a fenestration or dehiscence. Now, fenestrations are windows within the bone. On the left, you can see at the molar site where we have this window that has occurred with a small isthmus of bone that is traversing the alveolar process. Now, typically, periodontal ligament fibers can be inserting in the area. So if these areas are exposed without any, as a result of surgery, and there is not any disease present in the region, you want to very carefully protect these areas because you'll get reattachment. Dehiscence, on the other hand, is a U-shaped loss of bone that can be frequently found. Typically, they will extend half the root length, are more commonly found in the mandible, with the cuspid on the mandible the most commonly affected tooth. Fenestrations, on the other hand, is more common in the maxilla, with the maxillary first molar most commonly involved. Overall prevalence is about 20% of patients, where fenestrations can be found in about 10% of teeth and dehiscences in about 9% of the teeth. We'll talk more about dehiscences as we get into your Periodontics 3 course because they play a distinct role in determining what you can do in the case of gingival recession. This concludes this module on alveolar bone.